Hi, everybody. My name is Stephen Miranda. I'm one of the PGY4 neurosurgery residents at the University of Pennsylvania. And today, I'd like to thank the Pennsylvania Neurosurgical Society for giving me this opportunity to share our work today. Today, I'll be sharing the results of our effort to implement a streamlined care pathway to reduce both cost and length of stay for patients undergoing endoscopic transsphenoidal pituitary surgery, which I'll refer to as TSA surgery for the remainder of the talk. So as we know, relative to its peers, the US spends a great deal more on healthcare compared to other developed nations with unfortunately worse outcomes. So in the past decade, there's been a recent shift towards changing our healthcare systems towards a value-based system. So there are a number of buzzwords associated with the number of strategies that have been employed here: bundled payments, fee for value. A lot of them center around the idea of reducing the cost of particular episodes of care and reimbursing hospitals for entire episodes of care. Now, while a lot of this started in the primary care world, recently there's been a growing emphasis on the surgical subspecialties, as these are significant cost generators for many hospitals and healthcare institutions. As this process is ongoing, it's important for us as surgeons to be involved in the decision-making here, because not only do we do the surgeries, but we have intimate knowledge of the patients we care for and the disease we're treating. So before you can focus on reducing cost, it's important to know what the cost drivers are for TSA surgery. And a lot of literature suggests that length of stay is directly linked with increased cost. Because patients present in elective fashion most often, and because indications for surgery are relatively consistent, the more time spent on surgery and perioperative care can drive up the cost. Now, we've looked internally at our institution at patient factors and found that the presence of a post-op CSF leak, smoking status, ethnicity, among other things, can drive up the cost. But when it came to developing an intervention that we can apply uniformly in this population, we decided to focus on length of stay. And we hypothesized that if we came up with a streamlined care pathway for these patients, we can reduce both the in-hospital cost and the length of stay for our TSA patients. So a brief word on how things work at our institution. Prior to this effort, under the standard care, like other cranial surgeries, TSA patients were recovered in the ICU, then observed for a night before they were transitioned to the floor before discharge. For the INCU pathway, surgeons have the option to recover patients directly in the PACU before transferring them to a step-down unit for intermediate neurological care. And there, the nurses and the clinicians were trained to look out for the specific known complications of TSA surgery: postoperative diabetes insipidus and CSF leaks. Now, it's important to note there were no hard and fast rules for which patients had to go to the ICU or the INCU. It was left to the surgeon's discretion. If they felt the patient was low risk, there was no intra-op complications or worrisome concerns, the patient could be slotted for the INCU. But if there was any concern, on the other hand, they could be slotted for the ICU. So a bit of our note on our methodology. This was a single institution retrospective study. We looked at all TSA surgeries between July 1st, 2017 and March 30th, 2020. The INCU pathway is implemented on July 1st, 2018. In terms of our cost analysis, we did a multivariate linear regression to account for all of these potential confounders, both patient and surgery related. And we looked at costs and length of stay in terms of our outcomes. Now, costs can be either direct or indirect. Direct costs are related to directly providing the service. And some of these might be variable, such as labor or supply. The more service delivered, the more labor or supply costs are generated. Other direct costs are fixed, such as clinician salaries. Indirect costs are usually overhead, like facility charges or electricity and that sort of thing. Looking at our demographics, both groups were relatively similar. And we had a total of 187 patients in the study, 79 of which were on the INCU pathway. And in terms of age, gender, ethnicity, insurance status, both groups were relatively similar, as well as their comorbidities, smoking status, and Charlson Comorbidity Index, as you can see here. We also collected patient factors that could impact the surgery and its outcomes. We collected NOSP score, which denotes the relative degree of cavernous sinus invasion, maximum tumor dimension, presence of suprasellar extension, and whether a vascularized reconstruction was performed, like a nasoseptal flap. And again, both groups were relatively similar, although there was a trend towards larger tumors and more frequent suprasellar extension in the ICU group. So going directly to our results, in our univariate cost analysis, we found that the INCU pathway reduced length of stay and saved money. All these results, as you can see, were highly significant, and length of stay was reduced about over 1 day. We then performed a multivariate cost analysis, incorporating all the possible confounders that I mentioned earlier. And once again, the INCU pathway was successful, reduced length of stay by over 1 day and saved about $6,000 per admission. Most of this came from reducing variable direct labor cost and indirect costs at almost $2,000 a piece. The 95% confidence intervals you can see here, and again, all of the p-values are significant. We also, as we put together our manuscript, trying to look at some of the other patient outcomes in this group. Interestingly, we found that while intraoperative CSF leaks were relatively similar, there were no post-op CSF leaks in the INCU pathway. All these occurred in the ICU. But interestingly, there were more patients who had post-operative DI in the INCU pathway. Interestingly, though, this did not impact their length of stay. They still had lower length of stay and no readmissions, interestingly, in the 30-day post-operative period. So how can we interpret these results? So first of all, the INCU pathway was successful. It reduced in-hospital costs across the board and reduced length of stay by over 1 day. As we mentioned, the cost savings is largely due to reducing the variable direct labor costs and direct costs. And you can understand this because the ICU was bypassed in this group. If you can bypass the ICU, you can avoid the costs related to the clinicians and nurses in that setting, as well as supply costs for extra monitoring. Now, interestingly though, this study also shed some light on how we might be able to operationalize surgeons' clinical decision-making and clinical judgment in the value-based paradigm here. As I mentioned, we allowed for surgeon discretion in determining which patients would go to the INCU and the ICU, and it looks more often than not they decided correctly. The patients slotted for the INCU, even though they developed more post-operative DI, appeared to be lower risk. They had shorter length of stay and no readmissions. But the patients who went to the ICU seemed to warrant that level of care. They had higher rates of post-operative CSF leaks and more readmissions. Now, this could be related to the fact that the surgeons were selecting patients who had larger tumors with more supracellular extension, which may indicate a more involved surgery. But overall, our study was not powered to look at those things. But it sort of highlights this idea that surgeons should be involved and can actually make a difference in creating the value-based paradigm. And it's something that we should be at the forefront of developing. But going forward, further studies needed to understand which factors we can safely modify so we can continue to achieve better care at a lower cost. So with that, that's all I have. Thank you for your attention. And again, I appreciate the opportunity to share our work here today.